Welcome to PharmacyToDose, the Critical Care Podcast, a partner of the ACCP Critical Care PRN and a member of the Pharmacy Podcast Network. And I'm your host, Nick Peters. Wherever you are and however you are listening, thank you. Now, this is the trial of the week. We review a landmark study in critical care history, and it's time for our last September trial of the week, and we are reviewing an absolute landmark study today. One you could argue is on the Mount Rushmore of important research in the critically ill. And I'm joined by Brandon Hobbs to review the 1996 New England Journal of Medicine article, A Comparison of Low-Dose Heparin with Low Molecular Weight Heparin as Prophylaxis Against Venous Thromboembolism After Major Trauma. So we set the scene, what was care like prior to this study. Then we dive in, we dissect this study. We talk about the dosing regimens, how they monitored for VTE. We also then go to where are we now, right? How long did this study impact care? What is the guideline-recommended regimen now? What do we have an idea of what other centers across the country are doing, and much, much more. So sit back and enjoy the last Trial of the Week episode for September, which starts right now. So very lucky to have Brandon Hobbs with me. Brandon is a surgical critical care clinical pharmacy specialist and the PGY1 residency program director at Orlando Health, Orlando Regional Medical Center, and newly inducted a fellow in critical care medicine. So excited to experience the celebration with him at the FCCM Annual Congress. You can reach out to him on Twitter at WinterHog. Brandon, welcome. Thanks for joining us. How are things?
Things are great, Nick. And thank you very much for having me on the show.
So I have to ask, I think I'm probably familiar with what your handle is referencing, but for those who just heard your Twitter handle and have a confused look on their face, explain what that means.
Yeah, so it's kind of like a combo. So here's the thing. I grew up in Northwest Arkansas, and, I am a Razorback fan, till I die. We grew up about 15 minutes from the University of Arkansas, the campus. And so, I've had a Southeastern journey since essentially graduating high school. Ended up here in Orlando, Florida, and actually live in Winter Park, Florida. So that's right above Orlando. And so when I got on Twitter, it wasn't for academia or anything at all.
Yep.
I didn't even know that existed. I got on there to follow, the Razorbacks and the news. Since I was all the way in Florida, it's kind of hard to get news or whatever. And so I knew I could do it through Twitter.
Yeah.
And so when I was making up my name, it was, just a combo between where I live now, Winter Park. So that's the winter. And then the hog is, kind of like I said, being a hog fan. And it's also kind of, talking about me just kind of being alone on an island, one of the only Razorback fans in Central Florida. I feel like that's kind of how it always has been, because I was at the University of Tennessee College of Pharmacy, and then, residency in Atlanta, Georgia. So, just a lone Razorback fan.
And it's, I lived in the South for 2 years. Like, the football's different down there, right? Like, if you're in Atlanta and you're an Arkansas fan, right, that means blood on Saturday, right?
Yeah, I don't have a whole lot to say. When I was in Georgia or Tennessee, those fans are loud enough. And me being a number of one, usually when we're around watching the games, I just I kind of know my role. And if we're losing, I take it well. And if we win, I don't say a word about it.
Well, this is a Woo Pig Suey podcast, so don't worry. Let's go Razorbacks.
Oh, I love that. Yeah.
You and Melanie Condeni from MUSC. Those are you're the two Arkansas fans that I know. So now, listeners, right, we've established on these episodes, we're in the trust tree. Honesty, always the best policy. Longtime listeners will remember Anthony Hawkins and I at a conference talked about the Orlando airport and having conferences in Orlando. You heard from the intro, that is where Brandon works, resides just right outside of. So, Brandon, the floor is yours. Why is Orlando awesome? Why am I wrong? What does everyone get wrong about the city? I want to give the platform for you and all of the, is it Orlandoites? Is that what's the preferred nomenclature there?
I think it's Orlando.
No, that makes more sense. Okay. Yes. For you.
I think so. I think so. All right. So, I mean, this is a pretty complicated question, but to give you kind of the down and dirty, I totally agree that MCO, Orlando International Airport, might be the worst airport in the nation.
The absolute worst.
I will never defend that. I would rather go out of the little airport out in Sanford, Florida, than go to MCO. To really like Orlando, I think you have to get out of the touristy area. I've been to the amusement parks over and over again. I have 2 young kids, so those aren't my favorite places either at all. But, if you do come down to Orlando, you're in Central Florida, then, kind of venturing up, in my parks, Winter Park, I mean, it's a beautiful little city, a lot of great shopping, excellent restaurants. Central Florida is also just great for, outdoors if you can manage the heat. But, if you're a golfer like I try to be, then, you can golf 365 days of the year, although golfing in August is not, or all of summer, but July and August are just brutal out there. So, a lot of outdoor, a lot of nice breweries as well. So, I think Orlando in itself is, kind of a big foodie town. So, I'm not a huge foodie, but I know there's a lot of good restaurants, and I do like beer. So, the breweries, there's a whole Central Ale Trail that you can follow in Central Florida. So those are some of the things, I guess.
So it almost sounds like the tourist area in Orlando is like if you live in Nashville and it's Broadway, or you live outside of Vegas and it's the Strip, right? You're only going there if someone's visiting or something like that. And otherwise you're typically kind of staying, okay, that makes sense. All right. We cleared the floor. Shout out Orlando. The Orlando ends. Now let's get into our last trial of the week for September, right? A comparison of heparin and enoxaparin for trauma VTE prophylaxis. So, Brandon, as we set the scene, kind of starting out, historically speaking, where would you rank this in terms of like high quality trauma literature? Like, is this a top 5 study all should be familiar with going into like a traumatic surgical ICU, maybe a tier below, none of the above? Where do you think it kind of stands?
All right. That's a really good question. I think every clinician in the specialty of trauma, surgical critical care, they can probably relate to what I'm about to say. If there was one study and one study only that you could give your learner coming on rotation to read, I think it'd be this one. The topic itself of VTE prophylaxis and trauma is one of the most important topics that you could have for this population. And this study right here, it's fundamental to, your learning and your understanding. You also mentioned quality of the study. Well, this study is not without flaws. I'm sure we'll get into, some of those and some of the more significant ones. But really, no study is flawless. Even with the flaws, this study, to me, it easily ranked into the top 5, and could be argued that it's at the very top. But when you kind of add in the clinical impact of the study, this study changed practice in a global context for well over 20 years. So when you factor all of that, in together, it's hard to say that it's not number one in the trauma literature.
And it's one of those studies that personalized medicine hasn't necessarily taken us completely away from this, right? Like Crash 2, you'd probably put in that top tier, at least things you talk about. But now with tags and some of those other things, right, we may not use it as much as that study did. And this is something where, the dose might be the same, but right, like VTE prophylaxis, and that's what hospitals get paid for. That's how FTEs get created. So important things. So yeah, I like that you set the stage, because I completely agree. This is a must for everyone to hear. Now, and one other quick thing, actually, you mentioned the study itself. I'm actually like, when you go back and look at these studies, and we'll talk about they recruited in the early 90s, I'm also like impressed they're able to do these randomized double-blind placebo-controlled trials in the early 90s, right? Like that's even challenging now with the things we have, let alone, we don't even have the internet, all those things. So I think some of these, they're not without flaws, of course, but I think some of them age like some fine wines when you look back at the work of the authors. So prior to this study, right, we're talking, this is a trauma patient population. What was the patient population that had the highest quality data with low molecular weight heparin and VTE prophylaxis?
Yeah, so, thinking about this question, I think if we took, all clinical pharmacists and this was a multiple choice question, I think a lot of people could probably get this right. And I'm going to say it in a positive way. It's the specialty that is the most creative with their VTE prophylaxis, to say it nicely. I mean, and that's orthopedic. I mean,
Yep.
These guys, they use warfarin, they use aspirin, they use heparin, they use enoxaparin. So if you had to guess who that would be my guess and your guess, and you'd be right. It's it's orthopedics before this study came out.
What a great reference. If you've ever worked with orthopedics, so you'll have one person on 81 BID of aspirin and the other will be on 1.5 to 2 INR goal with Coumadin, right? Same procedure, same.
Yeah.
It's just, that's a really, really good point.
Very creative.
So let's get into the actual trial of the week here, published in September 1996 in the New England Journal of Medicine, entitled "A Comparison of Low-Dose Heparin with Low Molecular Weight Heparin as Prophylaxis Against Venous Thromboembolism After Major Trauma" by Geertz and colleagues. So, Canadian single-center randomized double-blind trial enrolling patients from 1992 through 1994. And this single center, level 1 trauma center in Canada. So the patients that were included, right, they experienced major trauma. They had to have an injury severity score of 9 or greater. And then they got further stratified according to the presence or absence of a lower extremity fracture. There are more exclusion criteria, but key ones to note would be likely death within 1 week and bleeding or coagulopathy seen on imaging or labs. So patients are randomized into one of two groups, either unfractionated heparin, 5,000 units sub-Q every 12 hours, or enoxaparin, 30 milligrams sub-Q every 12 hours. So they were both started within 36 hours of injury and continued for up to 14 days. And then of note, enrolled patients all received venous Dopplers between day 10 and day 14 to assess for a DVT. Now, the primary outcome, right, of course, that makes sense, we're leading into this, was proven venous thromboembolism. So 344 patients were randomized, right, and talked about the stratification according to that lower extremity fracture, and setting the scene for what kind of patients these were. Most common injury, lower limb orthopedic trauma. Most patients were male in their late 30s with an injury severity score of 23. So Brandon, fill any gaps. What did I miss or mess up? And then let us know what this Canadian research team ultimately found.
Yeah, thanks, Nick. Before I kind of get into the results, more into the results and everything, one thing about the methodology that I'll point out is that they all did receive, some sort of surveillance between day 10 and 14, and they did get venous Dopplers done in the patients that were symptomatic, like throughout. But when they looked at their primary outcome, they actually used contrast venography between day 10 and 14, which is going to be a little bit different than the duplex ultrasound. And, we can talk a little bit about that later, but I wanted to kind of get back into the results and talking about the patient population itself. So, you mentioned these trauma patients had a median injury severity score of 23. We're talking about severely injured trauma population. And that's really reflected in their hospital stay as well. Each group being a little over 3 weeks. So these are your highest risk patients that you're really going to see. So, working out their study population, they found the sick ones. They found the ones that have the highest risk for DVT. One thing I'll also note before the primary outcome is that a significant number of patients, more than 30 in each group that was actually randomized to their group, they weren't included in the final analysis because venography wasn't able to be done. So patient had their leg amputated, or there was a lot of different various reasons that they gave, but if they weren't able to get the contrast venography, they were taken out of the final analysis. So that brought the patient population, or the study population, down to 265 patients and 136 heparin, 129 enoxaparin. Now, the good stuff. So the primary outcome of all DVTs, they found 44% DVT in the heparin group. So 60 out of 136 patients in the heparin group actually had a DVT, compared to 31% in the enoxaparin group. So 44 versus 31%, this equated to a relative risk reduction of 30%, and it was statistically significant, p-value of 0.014. More importantly than just all DVTs, they reported out the rates of proximal thrombosis. So now, for all you listeners at home, proximal essentially means that the thrombus is either in the femoral, the iliac, or the popliteal vein. Essentially, what we're talking about is above the knee DVTs. And the reason why this is significant, because there's a much higher risk of the clot embolizing, resulting in a PE. And, that's the real danger that we're talking about. So what they found for the proximal vein thrombosis. Proximal vein thrombosis occurred in 14.7% in the heparin group versus 6.2% in the enoxaparin group, resulting in a higher risk reduction of 58% with enoxaparin. Again, this was statistically significant and clinically speaking, a more important outcome than overall DVTs. They also had subgroups. I'll just mention one subgroup. Risk of proximal DVT in patients with lower extremities was also in favor of enoxaparin. Relative risk reduction, and that was even larger at 73%. Now, for the switching gears and talking more about safety outcomes, the major safety outcome was bleeding, and events were minimal for both groups. In fact, only 6 patients out of the entire study population of 344 experienced a major bleed. 1 of them was in the heparin group, 5 were in the enoxaparin group, so 0.6 versus 2.9% respectively. This did not have, or this was not statistically significant, but was it powered to be? No, it was a secondary outcome. But they described, to their credit, they described every single one of these major bleeds in the actual article. And, some of them don't seem to be too major. Like some of them didn't even require packed red cells to be transfused. And then some just sound like, and the percentages there too, when you have severely injured trauma patients like this, some of them are going to bleed, whether they have chemical prophylaxis on or not. It doesn't matter. And so you can make your own, judgment calls on that. But to me, this was really minimal, significant bleeds that were found in each group. Other outcomes that we might want to talk about, PEs. There's only 1 PE found in the whole study. That happened to be in the enoxaparin group, but there weren't any fatal PEs in either group.
So clearly, like these were landmark findings at the time, right? You mentioned almost a third relative risk reduction and no real difference in major bleeding, low major bleeding. You even say so. Obviously, practice like changing now. As you mentioned, as we kind of went through, the thing that always stands out to me that I want to ask you, why do you think they used the Q12 dosing for heparin when, most of us, I would say, are familiar with the Q8 heparin dosing regimen for VTE prophylaxis, right? There's that chest study. It was mainly medical patients, but it showed Q12 and Q8 were similar. But why do you think the authors chose to do that here?
That's a great question. So this is, one of the biggest criticisms of the paper, and for good reason. This first one, before I get into really the main reason why I think, I'm going to give you kind of an excuse answer.
Love that.
And this is back in, when they did the study back in the 90s, heparin Q12, 5,000 Q12, ours was a lot more common than it is now. Now we hardly ever see it. I call it, my great grandma dose. And that's about the only time that I'll use it is for the, the little old ladies or
the
my
sweet old ladies. Yeah. Marge is her name, right? Or Esther.
Yeah. Yeah. That's her, and that's the only time you even think about it. Right. So, I think they thought they could kind of get away with it because it was a little bit more common. Even though we know trauma patients are hypermetabolic with an augmented renal clearance, not a good choice, but, so that's kind of the excuse reason. But, the big reason is that they wanted to do a double-blind study and really raise the quality and eliminate bias of this study. And the only way to do that was to dose the heparin at Q12. This is like one of those, great examples of, of a study when you have a student maybe or any type of learner on rotation with you, and you want them to kind of start thinking about how to critique and, recreate study design and methodology. I mean, this is just a great example to use because, you always say, well, could you double blind it if you do the heparin Q8 and enoxaparin at Q12? And no, it's not practical. It's not practical at all. So, that's the big reason. I had a double blind study. Enoxaparin was used both 30 Q12 and 40 daily, previous to this study. But when you're talking about the trauma population, doing a daily dosing for the half-life of enoxaparin in a trauma population that's at high risk and hypermetabolic and, like I said, with augmented renal clearance, and, there wasn't much of a choice other than doing the enoxaparin at Q12.
Yeah, I think it's easy to play Monday morning quarterback, but, doing like a double blind, essentially like a double dummy study, I think if you're kind of the researchers or the authors and you see that as a huge barrier to this study being successfully completed, right, at a certain point, you may have to make a little mini sacrifice for the greater good. So, yeah, I mean, this is such a good study. Definitely minor critiques. Now, let's talk about some of the ancillary care, right? And you pointed out, thank you for correcting me, by the way, that they received the surveillance imaging, right? So explain what the angiography, Dopplers, what does that mean? And then was this surveillance imaging and things, was this a common practice in the 80s and 90s at that time?
Yeah, another really good question. So it sounds like, I feel like I'm always, back in the 90s. Back in that.
We're going to the future soon, I promise. We're
rocking
getting there.
Back in the 90s, yeah. Surveillance imaging. So, one part of your question, surveillance imaging with duplex ultrasound. It actually was more common than it is now. That was actually when the studies were actually being done to see if it had had any effect or affected outcomes any. And what were the outcomes they were looking at? Most of the time, incidents of DVT, or not DVT, but where they're basically trying to find DVTs, specifically proximal DVTs. And if they did find the DVTs, then the patients would get full anticoagulation and prevent any pulmonary embolism. So, which are fatal. So that was kind of, the point for, doing surveillance, on a weekly or biweekly basis or something like that. But when they actually did the studies and looked at surveillance duplex ultrasound versus no surveillance, there wasn't really a decrease in the incidence of PEs. So that was kind of dropped. Even the guidelines, they don't recommend routine surveillance anymore. The only time surveillance is ever even recommended or suggested are in the patients that are at very high risk that can't receive chemical prophylaxis. That might be the only time that you do a duplex ultrasound. Now, this study went even further. They went a step further than duplex ultrasound. They actually used contrast venography to identify DVTs. And this is an invasive procedure where essentially dye is shot into your foot or your lower leg, and then special x-rays are taken to identify the DVT. And this is definite or definitive. It's gold standard. DVTs really are not missed with contrast venography compared to duplex ultrasound. The sensitivity and specificity is essentially 100% with contrast venography. And, compared to duplex ultrasound, that's going to be a lot lower, especially with duplex ultrasound. It's pretty good at, identifying proximal vein thrombosis, but not as much, in the lower part of the leg or below the knee. But when you're talking about contrast venography surveillance, which is what they did, nobody in practice does that on a regular basis. I've never heard of that at all.
Yeah, this was a step up, right, in terms of the monitoring for it. And I appreciate you setting the scene, right, because that was, right, it was Doppler Thursday, and everybody in the unit got Dopplers, right, and that was just that was the era, right. I think it's always, when you're looking at these topics, kind of interesting to go back and see how care has kind of progressed and changed, because in theory it makes sense, right. We know the issues and the downstream effects, why we work so hard on venous thromboembolism, that the idea of maybe prophylactic surveillance, right, it makes sense. It just didn't necessarily work out. So let's talk about, right, landmark study, and where are we now with this? So when the authors were designing this study, when you look in the statistical analysis section, right, they estimated the event rates in approximately 45 to 50%, essentially, incidence of VTE. So what are our rates now that we have an increased emphasis on VTE prophylaxis? Because I'm guessing it's not 45%.
Yeah. So, first of all, I think this is a great question, and it's really hard to say. And I hate to, ever give this as an answer, but it really depends. But let's kind of, because the question has several layers. So let's kind of, talk about, some things that matter. So if we're talking about, DVT rates, what's going to matter? Well, we know one thing, the higher the injury severity score, so the more severely injured a trauma patient that you have, the higher risk of VTE. We do know that. So if it kind of depends on what, subset of trauma patients are we looking at? Are we looking at all trauma patients that, come to your trauma center versus, patients that are severely injured with high ISS scores that are, ICU admissions, before they go to the floor? All that will matter when you're kind of talking about DVT rates. To the credit of this study, they use really sick patients. We already talked about it. ISS score on average was 23, like for both groups. And a lot of people say, or you look at the scores, anything above a 15 is, a severely injured trauma patient. So that's one thing. It's kind of like, what trauma patient population are you talking about? And then the other thing is, are we talking about just documented DVTs versus all the DVTs? Even the asymptomatic ones that, only God knows about, that our patients aren't able to tell us, and we don't do surveillance anymore, or anything like that. So, now it's symptom-based diagnoses, or along with like physical exams. So a lot will kind of, compared to this study, which found 44, remember, and 31%, the rates are going to be a lot lower than that, because they found every single DVT that there was in their patients. So I guess putting a percent, I think, is hard. But if I had to give you a range of, trauma patients that are moderate to severe, I would say probably about 10 to 30%, and that's like all DVTs. Now, the percent diagnosed and actually documented, it's going to be far less than that, with a lower range. You mentioned like our early use of VTE prophylaxis now, and most trauma centers do emphasize chemical VTE prophylaxis within 24 hours. And we really have this study to actually thank for that. So back in the 90s, patients wouldn't get DVT prophylaxis for days, sometimes, because of, the quote unquote bleeding risk. Well, all the patients in this study were started within 36 hours. So not only did we get the preferred medication for VTE prophylaxis and the starting dose as practice changers, we also got early start of enoxaparin is safe in our severely injured trauma patients. All patients within 36 hours. They even included spinal injury patients. Of course, they left out TBI patients. That's a whole different topic. But, I think that just adds another layer to this study that sometimes you don't think about, is that, they were really, pushing the envelope on start times too. And this was the beginning of that, of how we do things now.
I love that you pointed out, right? Like almost 20% of them had a head or spinal cord injury. So the idea in the early 90s of everyone getting started VT prophylaxis within 36 hours, that wasn't, it was much harder to try to actually make that happen in practice, right? We're much more progressive, I think, with starting and understanding the risk of thrombosis versus bleeding. I think that's a really good nuance, because this is that's like when you get asked a question and you're like, I know that answer, but I need to like ask 3 more. That's like the idea of like, I know that answer, but you almost have to give like 5 caveats because there's so many things to consider. So I thought that was a really good answer.
Yeah, that's a good way to put it.
What do the guidelines actually recommend? What's our guideline recommended regimen for prophylaxis against VTEs?
Yeah, this is a lot easier question. The question before. Well, now we actually have 2 recent guidelines, which is awesome, because we didn't have anything for a long time before, and everybody was just kind of, out in the desert by themselves, trying to figure out, is 30Q12 still the right dose anymore? But, I'm getting off track. But our 2 recent guidelines, we had Western Trauma Association in 2020, and then AAST, ACS, COT 2022 published guidelines, and both of them recommend a new dose, enoxaparin 40 milligrams Q12 for the majority of trauma patients. So, finally, so that's the longevity of this study. Like the same dose, like was, being recommended, everywhere for, what is that,
like 25 years, 25, 26
years. Yeah. And when does that happen? Not very often. So, that's just the impact of the study. But 30 milligrams Q12 didn't just go away. We're still going to use it, especially for kind of our special populations. You know, so elderly patients, anybody above 65, patients with the so-so creatinine clearance of 30 to 60, and low total body weight, less than 50 kilograms. The recommended starting dose is still 30 milligrams Q12. And then also you have your unique populations within trauma, so spinal cord injury, TBIs. The suggestion is to start them at 30 Q12 as well, because we just don't have the safety data with that higher dosing yet. So maybe in the future that could change, but for that population, I think it's good that they kind of singled them out and was like, you might want to start at 30 Q12 still, and then monitor and adjust from there. Oh, I almost forgot the best part too. Obese patients. This is where it gets a little bit muddier, I guess. AAST guidelines, they suggest weight-based dosing, so 0.5 mg per kg, Q12 hours, and they actually give a BMI threshold. The BMI threshold is 30. So anyone above 30, you should, or they recommend to switch to a weight-based dosing of 0.5 mg per kg, Q12. Western Trauma Association, they agree with the weight-based dosing. They give a range of 0.5 to 0.6 mg per kg Q12 as an option, but they don't really comment on BMI thresholds like the AAST guidelines. They do suggest, the one suggestion that they do is on total body weight. Anybody above 100 kilograms should start at least at 50 milligrams Q12.
So, yeah, I love that you highlighted all the different kind of dosing regimens for those different populations that you can see in trauma. I guess, this study, right, we just talked about a mainstay for 20 plus years. We also know change in medicine is hard, right? Especially when you've been doing something the same way. So with the updated dosing and things, do we have a feel for what hospitals or other centers are doing across the country as it relates to trauma VTE prophylaxis?
Yeah, we do. Thanks for asking the question. So sandwiched between the two guidelines being published, so 2020 and 2022. In 2021, our team at OMC, led by our former critical care resident, Sydney McNeil, along with a colleague at UF Health, Shan, we actually performed a survey study of critical care pharmacists on this very topic and trying to answer that question. Essentially, we definitely felt that practice varied significantly. When we first started talking about the survey, not even the first, guideline had really come out yet, the WTA guideline. So we were just wondering, what is everybody doing? Because, we were kind of struggling ourselves because there's all this data based on anti-10A monitoring of, that 30Q12 is underdosing, but has anybody made that change? Has anybody been bold enough to do that? What we found, and now this might be much better now because it's 2 years later, and AAST has also come out recommending a higher dose. But what we found was that 2/3 of trauma centers were still using 30 milligrams Q12 as their initial dose, and most of the respondents came from level 1 academic centers. So these are, clinicians that, know the data and know that, but, we just hadn't made, and I'll even say, myself, we didn't update our guidelines until, kind of recently. So, that was kind of one thing that we found that was a little bit, but not particularly shocking. The other thing is that we also report on obese patients. They were routinely given a larger dose, and guess what the larger dose was? 40 milligrams Q12. But the most common threshold was BMI greater than or equal to 40. 78% of our respondents didn't dose adjust from that 30 milligrams until BMI was above 40. And then it was, and the dose adjustment was to 40. Only 3% of the institutions that responded were using a BMI of 30, which was recommended the following year in the AAST guidelines.
Well, this is, featured in the May Literature Review Series, the JACCP article. I love that you highlighted it, because this is great, because this is also, right, it's the guidelines say one thing, right, but it's very in a dynamic population like this that really can vary from center to center. It's cool to get kind of a picture of what everyone is doing. Now, I got to say, I said this on the episode, I'm going to have to say to you, I need to talk to the one place that's got heparin as their preferred trauma VTE prophylaxis agent. The answer is 99% enoxaparin, and you got this one lowly center. So open invitation, whoever that center is, come on. Got a couple questions for you. But no, awesome work from your Florida colleagues. Definitely check that out. Listen to that May episode. Brandon, thanks so much for your time highlighting such a landmark, what this Trial of the Week series is kind of about. These really historical articles, still important. Reach out, let Brandon know what you thought at Winter Hog. And Brandon, appreciate your time, effort, energy. I'm glad that you got past melting season, aka Florida in summer, and we're coasting through in September and into October. So take care.
All right. Thanks a lot, Nick. Appreciate the invite, and it was a pleasure.
Thanks again to Brandon for all his insight. That was great. Let me know your thoughts as we go into October at PharmacyToDose or PharmacyToDose at gmail.com. Reference list with those guidelines and things, as always, is in the episode description. Website's coming. Give me just a little bit longer, team. It's going to be worth it, I promise. But until next time, I'm Nick Peters, and this is PharmacyToDose, the Critical Care Podcast. The Critical Care PRN optimizes drug therapy outcomes by promoting excellence and innovation in clinical pharmacy practice, research, and education. For more information, go to critprn.accp.com. Again, that is critprn.accp.com. The podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The content and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the content and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. Users and patients should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.